is great. I think you covered everything. I want to talk a little bit about your thoughts on the government systems, veterans, Medicaid. Do you see this working? If so, why and when? Yeah. What are your thoughts on the government program adoption?
Yeah, I think, from a government program adoption, the administrative fees are generally much lower than the private sector. So the federal government, through its size and scale, generally can get a lower administrative cost. An example of that being that CMS administrative cost is much lower than the average commercial health plan. The value to the federal programs is, one, these are very large programs that have a material impact on the GDP as well as the long-term financial future of the United States and its citizens. And so adopting these technologies and solutions to the federal government will actually have a huge impact on the quality of life of Americans in general, but more importantly on the financial well-being of the nation as a whole long-term. So addressing very large programs such as Medicare, Federal Government Department of Defense, Medicaid, through the same processes that we are within Arizona Care Network, will actually have a cumulative effect and will be in the best well-being of the nation as a whole financially and in terms of development. I always think of every dollar we spend on healthcare is a dollar not spent elsewhere in education, roads, infrastructure, etc. We want to make sure that we get the maximum value out of the healthcare dollar, and if we can reduce the cost, we can put that towards improving our communities in general, which is a necessary long-term sustainability of the country. So I think it has huge applicability. The federal government has the same challenges in terms of legacy systems that we have in the private sector, and so the problems are very similar. The scale is just different. So I think as we design and roll out, we always have in mind that what we bring to the private sector is going to reduce reliance on the public sector financing of finance and therefore indirectly help the federal government. And as we engage the federal government in these programs, I think we benefit every single taxpayer in the United States, which is good for our economy, good for our security situation, and good for our long-term growth as a nation.
So ACN's parent, Dignity, does a lot of work with the Veterans Administration. It's not been easy to work with them. So do you see Solve.Care being directly relevant to those challenges between the two?
Yeah, I think so, Pradeep. I think from a Veterans Affairs perspective, they have a mission to serve the needs of veterans long-term as part of their commitment to those soldiers. And so access to specialist services in some areas within the Veterans Affairs Administration is somewhat limited and restricted. And so if we can use our blockchain technology, and we intend to make sure that we can match the demand for healthcare services and availability, for example, within a large national health delivery system such as Dignity, through blockchain technology, I think we can speed up access to those specialist services, which is in the benefit of the veteran. It also acts as an extension of the Veterans Affairs System's delivery system and making sure that they meet the needs of the veterans. And then more importantly, through our payment innovation and the speeding up of payments, that will improve the current delays and difficulties associated with the volume of payments and the timeliness of payments from the VA to a system like Dignity. From a revenue perspective, being paid for the services you provide in a timely manner has a huge impact on the financial sustainability of nonprofit organizations such as Dignity. So it's a win-win for both of us, and I think we should encourage that kind of private federal partnership in the best interest, and rather than us developing separate technologies that don't talk to each other and has its own inherent cost and things, why not use what's available to the best interest of everybody? And I think our solution is that kind of solution. It also lastly protects the investments that both Dignity and the Veterans Organization have made in their legacy systems, which made sense and had its value when they installed them. But because of the size and the complexity, there are needs to make modifications to that. And I think unbinding ourselves from legacy system dependability means that we can move forward with new technologies such as blockchain while protecting the investment both organizations have made. So in other words, we're not going to, from a philosophical perspective, prevent advancement in the health delivery system administration and payments to be essentially hijacked or controlled by legacy system lack of interoperability. I think that amount of delay is no longer acceptable. So when you look at the federal government spending billions of dollars through the high-tech and the interoperability, we can all agree that it's not where it needs to be.
Yeah.
It's unlikely to change, and why would we continue down that road? So I'm excited about blockchain because it can unhinge us from the legacy system, slow design process and modification, while maintaining the value of those legacy systems.
Yeah.
And so it really is a win-win for both.
So you and I talked recently to the Medicaid organization, managed Medicaid organization that's responsible for delivering care to the poor, again, in that region. And there was a lot of excitement around cost savings. So why do you think this has not been done before? I mean, clearly they're talking about hundreds of millions of dollars a year that they are spending on questionable expenses related to medical care. And after we present it, clearly there's an opportunity. What are your thoughts there? Why does that need exist? Are we the right people to solve it?
I think that there is general resistance to change. As human beings and as systems are designed to get into a new equilibrium and remain there, and we're very good at protecting known systems of care and systems of administration. It is firstly very expensive to make changes. It's sometimes more expensive to not make changes, but it also requires changes in how we view problems and how we tackle problems. And I think what is really needed to innovate and transform healthcare is a new paradigm of thinking. To say to yourself, the challenge that we have are manageable as long as people of goodwill are willing to make changes in the best interest of all. And so I think organizational change or system changes requires the senior leadership to say that status quo is not acceptable, even if it's comfortable and successful, and to be willing to look at new innovations. And then lastly, I think we are at a phase now where we are very unified in our view that the current health delivery system and administrative system is not sustainable financially.
Right.
And if we do not make a significant investment in changing how we deliver healthcare and administer healthcare payments, that we will not be able to afford that, and that will have a significant negative impact on most communities, and that's not something we're willing to accept. So bottom line, the pain is severe enough now that most people want to change. I think we should grab this opportunity. We just have to be very mindful as we work on this that we do not create new additional problems that don't add value. So when I talk about administrative simplification, automation, these are not empty words, they need to be measurable. And I think there is also a need from society and from the legislators and the policymakers to have a much better insight into the consequences of the technology systems in terms of the changes they can drive and the potential return of investment. So for example, as we look at transport funding across Medicaid, that's a significant budget item. It is a significant challenge to do that, and we know that it's not as efficient as can be. So if we can use our solution to actively manage the referral process, the transport system, the various voucher systems in an actively managed ecosystem, I'm convinced that we can take significant waste and duplication out of the system. And just like we attack better care, more satisfied patients and providers, we really have to attack the administrative cost. We've left that piece out. On the assumption that we can deliver health care and that improvement in community health are going to drive the most savings. That is certainly true long term, but long term to change culture, behavior, and choices that individuals make and society provide is a much more daunting challenge, and it takes time to get there. There are short-term wins that we can get through administrative optimization, that will give us the runway and the time to get to the long-term population health changes.
Okay.
So they must run in parallel with each other.
And the scale is big, right? You mentioned earlier today that administrative cost is 20% of thousands of billions of dollars a year, so it's not a small amount of savings.
Right. If you look at GDP, about 19 to 20% of GDP is spent on healthcare in the United States, $1 in $5. Of the $1 in $5, about 20% is spent on administering the system.
Yep.
We can certainly reduce the administrative cost of delivering the administration of healthcare payments and various other things through our technologies and our innovation. And that's a very important down payment on a long-term healthier nation with a more sustainable healthcare cost.
Yeah. Going back to Medicaid transportation, what do you think is the scale of the adoption and the timing of this? In your mind's eye, how far are we from Medicaid jumping on using Care Wallet to automate this transportation use case?
4 months.
From today?
I would say that that's something they have to roll out January 1st. If you look at the amount that they spend on healthcare transport, which is a major cost to the Medicaid program. It's not a major cost to a commercial or the federal programs. Yeah. On the Medicaid side, we can address the active management and the auditing and the simplification by using new vehicles for transport and new mechanisms. I think that the return of investment is very short, and there's a very good down payment on the long-term strategic work of actually improving healthcare delivery through patient engagement, changing diet, exercise, preventative care, etc. So I think it's going to happen quickly now.
So the final question is, if you were practicing in Canada or South Africa, what would you use Care Wallet for there?
One of the challenges in Africa around payment systems and infrastructure is that there isn't infrastructure and payment systems. So a distributed ledger, digital currency makes a lot of sense in Africa where there aren't banks and all the infrastructure needed. So in a South African environment where most patients have a communication tool, communicating through cell phones, doing your banking, your business, your shopping, and everything through your phone call is a natural extension to take that to healthcare payments as well. And so I think it has a much greater opportunity to be adopted and spread than in the Western developed cities, because there's less legacy system dependability. Yeah. So I think that mobile payments through distributed blockchain technology with availability, think of the immunization record, think of the way to get paid for, to reward patients, probably has a much faster adoption profile than in the West, where you're disrupting so many ingrained self-interest groups.
Yeah.
So actually it's an interesting thought.
And same with nationalized healthcare systems like Canada and UK. Same. We hear that while they are nationalized and centralized, you don't really have a value for blockchain. I'm not sure that I agree. What are your thoughts?
No, I don't think, I'm thinking, for example, of the national health system in the UK, where they have a very good EMR and a national medical record for patients, and the physicians have access to that. I think in that case, the blockchain technology is really more about engaging the patient in better decision making. So I think the focus may be different there, where they are able to share information through big national registries, etc. I get that, but they can now change patient behavior by providing information to patients so that they make better decisions. So if we have in the United States an issue with emergency room utilization, I'm sure it's the same in England. Yeah. And the price point's just different, but it's the same problem. So I don't think I agree with, since we have all the data already in the central registry and we're distributing it across the system, that we don't need improvement in administration and or empowerment of the patient. I think those are separate issues. And it sounds more like a legacy system protection approach than a innovation. And then lastly, If having all the information in one place in a central data registry would solve our healthcare quality and cost problems, would have been solved a long time ago in the rest of Europe. And that's not the case.
Right.
So clearly it's not the total answer. The holy grail, in my opinion, for healthcare transformation is an enabled, empowered, and informed patient that makes better decisions with the healthcare team when those decisions need to be made. And we're not there.